in many ways, I am deficient compared with Harlan, not the least of which is that I cannot do my talk in Chinese. And so I apologize about that.
This is
but
an English session.
I'm truly honored to be able to present and discuss the updates to the 2025 ACC AHA and really multi-specialty guidelines, which I'm not focusing on given the prior presentations, but are largely influenced by some of the excellent science coming out of China that we've already heard about. These are my disclosures, and it's a pleasure to not have any conflicts with what I'm presenting, but for transparency, I want to do this. So this is data from the US, and it's focused on men, but we continue to have an enormous challenge in recognizing and addressing hypertension. And in the NHANES study, which is an assessment, a nationally representative assessment of community-dwelling people in the United States, I'm going to focus just on the overall practice patterns. And so it turns out in our country, less than 60% of people who had hypertension when examined even knew that they had hypertension. It turns out that less than half of those who are hypertensive when examined had any treatment for their blood pressure. It turns out that of those treated, less than 2/3 had a blood pressure less than 140/90, and less than a quarter had a blood pressure less than 130/80. This is an enormous challenge in the recognition and treatment of blood pressure in the US, and it really mandates strategies to improve the recognition and treatment of hypertension. And so this year was published an update to the 2017 guidelines, and this is a 120-page document. And Harlan asked me to read it page by page, but I didn't think I could do it in 20 minutes. And so what I wanted to do was highlight some of the key issues that need to be considered when thinking about or key insights that I got from these guidelines. So what's new? What are the innovations? And it includes information on detecting and monitoring hypertension. And you'll see here, I've got a whole bunch of them, but they're so gray, it's hard to appreciate. But I'll go through each of these. So the first is detecting and monitoring hypertension and the growing role of home-based monitoring. And this is a new evolution in priority from the 2017 guidelines. So the diagnosis and categorization of blood pressure is largely unchanged in the sense that we still need to average 2 or more blood pressures on 2 or more separate readings. And we have to use the highest blood pressure in order to assign people to either being normotensive, having elevated blood pressure, or stage 1 or stage 2 hypertension. And the process of measuring blood pressure is theoretically easy, but technically actually quite difficult in that the patient's supposed to refrain from any caffeine or exercise or smoking for at least a half hour before being measured. You have to have a very accurate measurement. You have to administer it in the right way. The patient has to be relaxed. You have to average multiple measurements. And because in reality, we all know this is not done in most routine outpatient visits, at least in America and outside of clinical trials, it becomes difficult to know whether or not you can trust the inpatient assessment of blood pressure, the office-based assessment. So focusing at the upper point here, we sort of have 4 different categories of hypertension. We have normal people who both in the office and at home would have normal blood pressures, less than 130/90. Sustained hypertension, meaning they always have an elevated blood pressure. Masked hypertension, it's lower at the office than it is at home or in routine life, which is a very interesting effect in the United States, where some people's home environment is more stressful even than going to the doctor. And so we see this disproportionately in socially disadvantaged populations. Or white coat hypertension. It's elevated when they see the doctor, but it's not elevated normally. And so because of this, a new recommendation, class 1 recommendation, is to start to rely and use home blood pressure monitoring to really confirm the diagnosis and to monitor response to treatment. The new guidelines also identify new treatment benefits of treating blood pressure well. And one that had never really been highlighted, but is very meaningful and motivating to patients to keeping their blood pressure under control, is a class 1 level of evidence A recommendation that in adults with a goal of less than 130 systolic blood pressures, it can prevent mild cognitive impairment and frank dementia. And so again, that's a new innovation in the updated guidelines. There is a fair bit of movement, and again, in part due to STEP and ESPRIT, that we should be much more aggressive in blood pressure treatment, and we should start to risk stratify. So, currently, this guideline recommends that if your blood pressure is over 140/90, then you need to lower the blood pressure. If, however, the blood pressure is, 130 to 140, well, then, does the patient have pre-existing coronary heart disease? And if so, you need to immediately start treating aggressively. If they have a high risk for cardiovascular disease or diabetes or CKD, and by high risk, it's using the updated AHA prevent equation with a 10-year calculated risk of greater than 7.5%, then you start initiating blood pressure treatment and medications right away. And if they don't, then you can try lifestyle modifications for 3 to 6 months. And this, and the goal for blood pressure treatment has gotten more intense. So right now, they recommend targeting less than 130 and ideally less than 120. And the idea is that, there was a lot of debate in the literature. Should it just be less than 120? And, they waffled on that, in large part because they didn't have access to your study and others. But it also, they wanted to make it to balance pragmatism against perfection. But they are strongly encourage getting a lower blood pressure. They have a class 1 recommendation for hypertension, increased cardiovascular risk for getting a blood pressure much lower than previously had been done, with a class 2B recommendation for those just at elevated risk. There has long been a approach in contemporary sort of U.S. medicine of start low and go slow. Don't rock the boat. Start a low medicine and slowly increase it to so that patients don't have a worse quality of life, don't fall, don't pass out, etc. And they've really moved away from that. So for those with stage 2 hypertension, they say right away, start at least 2 medicines, ideally combined into 1 pill. That is a big change in the way that we thought about treating hypertension in the 2017 guidelines and before that. For those with stage 1 hypertension, start 1 medicine first, and if you do try lifestyle, only try it for a few months so that you can start implementing medical therapy and up-titrate as needed. And this is a complex flow diagram, but I show it here only to highlight that only for normotensive patients or patients with elevated blood pressure but not stage 1 do you really try lifestyle therapy alone. For those with stage 1 or stage 2 hypertension, we move right to medical therapy to lower blood pressure. There is a need for also thinking about other treatment targets that can influence hypertension, particularly obesity and sleep. And I didn't want to go into great details about obesity management, but, apart from sort of diet and exercise, the inclusion of GLP-1 agonists, the new medical approaches to lowering rate are nothing short of transformational in making this achievable. And, there have been a number of studies now documenting substantial 7 to 10 millimeter of mercury mean blood pressure reduction after starting semaglutide or tirzepatide. And so I believe that this is going to be an increasingly emphasized part of future guidelines it got very cursory attention here, although they clearly noted that there are a lot of emerging and strong evidence that directly treating obesity with medications can be very effective at improving blood pressure control. Sleep health is another area that has become increasingly important and adopted in the American Heart Association's Life's Essential 8. And so sleep characteristics linked to hypertension have this rubric, are you sated? And so normal sleep consideration should think about the regulatory of sleep. Do you have consistent sleep and awake times and the duration of that? There is also improved efforts in trying to improve the subjective quality of sleep or satisfaction. Being alert during the day and staying awake versus not, indicating potentially suboptimal sleep. Timing when one sleeps. There are impressive and ever accumulating data that those with off-cycle or nighttime work hours versus daytime work hours have higher blood pressure. And again, this links to the regularity. Shifting from night to daytime work, as we make all of our residents do in training, is probably not very good for sleep health or blood pressure. The efficiency of sleeping, how much time you spend while in bed sleeping is very important. Insomnia being a big challenge and issue. And then the duration, the number of hours of sleep per night. And then directly addressing sleep disorders, even though there is less strong evidence about treating sleep apnea and blood pressure lowering, there are numerous reasons to treat sleep apnea, same with insomnia. So the team-based care is something that I wanted to spend a little bit more time because this is, again, an important new innovation in thinking about blood pressure management, blood pressure control. And the recommendations, level 1 recommendations for adults with uncontrolled hypertension, building a team-based care approach to assess and maintain and titrate blood pressure medication is very important. And then for adults with uncontrolled hypertension, integrating home-based blood pressure monitoring with team-based care is strongly recommended. And so the responsibilities and role of a hypertension team are to ultimately communicate with patients and engage in shared decision-making so that people understand why they're being treated. If any of us are just told to take this medicine and not told why, it's hard to imagine that we will be very adherent or really embrace that. And it is impractical for each physician and each patient to have all of the time available to communicate and engage in shared decision-making with patients and to coordinate care among different team members with the patient and other patient caregivers. The effective use of evidence-based diagnosis and management guidelines should be influenced and enforced by multiple members of a team. Regular structured follow-up mechanisms and reminder systems being developed to monitor patient progress and analyzed routinely by a team is needed because no individual person could be on top of an entire patient panel's blood pressure control over time. Supporting medication adherence and patient education is another major responsibility of team-based care, as well as the initiation and up-titration of medicines. And finally, the use of evidence-based tools and resources to maximize self-management is not something one person can do alone. And so when you think about the structure of a team, certainly there should be a physician who manages sort of routine and complex hypertension cases and helps coordinate with the other members of the team the therapeutic goals. And when there's very complex hypertension, engaging cardiologists or nephrologists can be very advantageous. Nurses play a very central role in accurately measuring blood pressure, in providing a lot of the education, the self-management and lifestyle modification support to maintain adherence to treatment. Having a clinical pharmacist who can adequately assess drug-drug interactions and help up-titrate and monitor response to therapies can be incredibly important and valuable, as can a dietitian who has the expertise to help engage people in understanding why following a low-salt diet or monitoring their calorie intake to lower their weight is so important. And then there's been an increasing recognition in the U.S. of the challenges of social determinants of health, transportation barriers, affording medicines, getting follow-up, and the need to engage the community to help support patients in managing their blood pressure and monitoring their blood pressure control. All 8 of these people can be part of the team. Not every institution can have it, but to think about extending and helping distribute the responsibilities for management, I think is very important and recommended. And finally, creating medication adherence strategies to help support patients actually take advantage of the insights that we heard about earlier today by taking their medicines and following it. And so there are things we can do like dose consolidation, single pill formulations rather than separate pills, a lot of the team-based coaching, creating electronic and whole blood pressure monitoring and teaching people how to use that and get feedback so that they can start to learn how their blood pressure is better after they follow their diet, exercise, sleep better, avoid alcohol. These are key opportunities. Integrating patients' preferences and values and shared decision-making into the management plan so people understand and want the therapy that we're trying to offer them is very important. Thinking about different reminders and self-management strategies can be very valuable. And then technology is a new and emerging aspect that got increased attention from the guidelines that I think has been very helpful in thinking about the opportunities to improve blood pressure management. The use of digital reminders. Patients can start receiving texts and emails, and there have been a lot of that done here in China. And then for providers to get EHR reminders in clinical workflow or to participate in registries so they can get feedback on the success of their management. And then thinking about telehealth population management strategies is very, very important. So a lot of this, and I'm just going to take a quick picture because I'm so proud of Jack in doing this, but a lot of this is going to be amplified in the November 4th issue of Jack. And so not only will several of the papers be published that you heard about here, but here is a perspective. Almost all of these are perspectives of different experts on different management of hypertension talking about what it is in these guidelines, what do they represent. And Jack is now trying to help provide much richer clinical context for interpreting 120-page plus guidelines that come out. So we as the practicing medical community can have a renewed focus on what we should be learning as guidelines or practice recommendations change over time. Thank you very much for the opportunity to present. I look forward to answering any questions you might have.